Good morning, everyone. My name is Angela Bradard, and I'm the manager of patient services at the Georgia Transplant Foundation. I'm so happy that you're here today. Everyone here is liver? Fantastic. I would like to introduce Dr. Stein. Dr. Lance Stein is a transplant hepatologist at Piedmont Transplant Institute who specializes in liver diseases and transplantation. Dr. Stein is the medical director of Piedmont's Living Donor Liver Transplant Program. His special interests include viral hepatitis B and C, management of the complications of liver cirrhosis, including portal hypertension, metabolic liver diseases.
All right, sure. All right, you got it.
Okay.
All right, so thanks for having me. I see familiar faces. I see a lot of our recipients. Anyone from Emory here, raise your hand. Sweet. So we got a good mixed crowd, half and half, which is what we expect, I guess, because it tends to be about half of the transplants are at Piedmont these days, usually about half are at Emory. Anyone not had a transplant? Excellent, because that's really what I think the focus is going to be on today. It's really for you, and I hope those in the room who had a transplant, you can lean on their experience, because we often address transplant in two phases, right? You have organ failure, you need life-saving transplant, that's why you're here. Or you've had a transplant and you need chronic long-term care to continue to have good quality of life, long-term outcomes that are perfect. And everyone's situation is nuanced. Just look in the rooms, I know everyone has had their own issues as it relates to them, at least the ones that I know. And that's great. If you guys, I really want to use this opportunity. GTM, I think, likes these in a didactic. I prefer this to be a non-didactic, right? You guys have a hepatologist in front of the room and hopefully in a non-threatening manner, right? Particularly if you're coming from Emory, you don't have to feel embarrassed because I have no idea who you are. And you can ask what you think might be dumb questions. They're never dumb. That you're afraid to ask your doctor or your transplant team, and then kind of see where the conversation goes. But to kind of keep the conversation moving, if you guys are a quiet bunch, I have some points that I'd like to talk about, things that are trends in transplant, in particular liver transplant. Things are always changing in our field. Things change both on the medical treatment side, whether it's related to liver diseases or having had a transplant, immunosuppression. Things are changing as it relates to technologies. So I think it's important that we kind of bring you all up to speed as it relates to what you may hear doctors telling you or what you actually might experience if you get called in for transplant and then in the post-transplant experience. Sound good?
Yeah.
Good? All right. You guys have burning questions? Because if you do, just hold them for a second because I'd like to address them. Because what I find is that if one person has a question, it usually means that other people in the room have the same question. They're just afraid to ask it. So there's really no bad question. Let's see if this will adjust. All right. So I just put my thought. Literally, I did this last night, so I was a little late to the game. But these were just not all inclusive, but topics that I think are kind of more new in the liver field. Some of them aren't new just by the verbiage, but there might have been tweaks or changes that we do. And these are a lot of the things that you will hear about as you go through your journey. So put on the left side kind of the pre-transplant stuff and the post-transplant stuff on the right. So questions about how do we think about transplant? I think a big one that always that comes up is, do I need a transplant? Why now? Why not now? Will I ever need a transplant, right? And so getting into the doctor's head of when do we start to talk to our patients about transplant surgery? Because a lot of our patients have cirrhosis and theoretically have a chronic liver disease that needs transplant, but not everyone needs transplant. Got me? Tips is a big one. Often our patients with end-stage liver disease or cirrhosis will come to us and thinking they're coming for transplant, and then the physician will say, aha, I'd rather talk to you today about a TIPS shunt procedure. Has that happened to anyone in this room? Raise your hands. Couple? Okay. What's that?
They tried. They couldn't do oral meat.
Yeah. So, but that was an intention. Yeah. So we can talk about that. If you have questions about that, organ allocation is always a big one, right? If you hear the general talk downstairs, I'm not sure if they talk about heart allocation, kidney allocation, but liver organ allocation is constantly going through updates and changes. And the big one was just before COVID for us. It's only been slightly modified since, but it really relates to how you get an organ, what kind of organ you get, and that field is constantly changing and updating. And if you start Googling, you get lost because it's hard to follow this stuff on Google, I can tell you that. And then machine perfusion technology is really the new one for 2023 and beyond. And that's going to affect a lot of you. And this is really the biggest positive of the field in the current era. And I'd like to update you guys on what that is. And then post-transplant management sometimes will come up. A lot of this is discussed when you do the education classes before transplant or immediately after you've had transplant before discharge from the hospital. Types of immunosuppression we use, you got some questions about that. Common infections that we see and common infections that we're looking for. And I put CMV on there just because it's one of the more common infections we see after transplant, but it also has some changes as it relates to clinical trials for vaccines as well as treatments. Various outcomes and complications, right? We always talk about worrying about a blood vessel clotting off or the bile duct tubes not being open wide. So that comes up. And then I put disease state monitoring, meaning looking for recurrence of the disease that caused the liver failure, because many of them will happen again after transplant. All right. So we when you see us in the clinic, are constantly looking for, did your disease come back? Right. This is, hopefully you've seen something like this, but this is a non-normal liver, right? This is when you get surgery and we take your livers out, they're generally going to look like this, which is lots of nodules, very shrunken in size, and not healthy looking. It should be smooth, shiny, and pink, right? That's what a liver looking like this normally should be, smooth, shiny, and pink. All right, so this is the most updated data. The slide's a little small, so I'll read some of this, but this is pulled directly from what's called the OPTN website, which is one of the governmental organizations that regulates transplant. So this is the Organ Procurement, I forget what it stands for, Transplant Network, something like that. But it's a governmental agency that regulates transplant. UNOS is a non-governmental agency that gets a contract from the government. And so we have lots of people that the transplant world answers to. And again, it's easy as a patient, particularly if you're sick, to get lost in the weeds, and no one expects you to do that. So feel free to ask questions, right? This is the data from 2021. So the number of patients who need a liver transplant, those who are on the liver transplant wait list, how many are getting a liver transplant, right? So that's the need, the solution being living donor versus deceased donor transplants, and then the success, right? The number of patients who actually were brought to transplant. That number has generally been rising. It's always been classically around 7,500 to 8,000 livers are donated per year successfully. It's actually rising closer to 10,000 now. And I think in 2021 it was 9,200. We expect that number to potentially rise by as much as an additional 50% in the next 3 years. The reason for that rise, meaning more donors, is machine reperfusion technologies. All right, that technology is really changing the game for the type of donors that we can utilize for you all safely, and the number of donors that we can safely utilize. Organs that would have normally been not considered by our surgeons are now being considered, and now there's lots of data over the last year being published showing that donors who have prolonged cardiac death, donors who are older, as old as getting now over age 90, are being successfully transplanted to patients with good long-term outcomes because the organs are being put on these pumping machines, which function like a closed circuit where the organ is put on essentially like a heart-lung circuit, right? And it's pumped outside the body, and then the health and viability of that organ can be monitored before the decision is finally made, say, to use it. Whereas in the past, we did it all by judgment. We would look at an organ, we would look at the patient's characteristics and how sick they were at time of organ donation, and the judgment call was made about whether we thought that organ would be safe or not. And if it was safe, thought to be safe, it would be given and utilized, maybe some matching to the appropriate patient. And by then, it was a good faith that we hope it works well for you, right? And now we don't have to worry about the good faith as much because these machines are now teaching us and now learning that we can learn the will it work while it's on the machine. And then the outcomes are excellent once they are utilized. And that story is not told in 2021, which is where this data comes from. That story is being told from late 2022 and beyond. And really, the number of organs being pumped in this country is exploding, going up extremely rapidly. Every transplant center in this country there's more transplant centers every month adopting this technology. All right. So I know Emory has adopted it. We are in the process of bringing it on. And some of the OPOs, which are the organ procurement organizations who bring donors to you all, they are doing it actually on their own without the need for the transplant center to request it. So Georgia hasn't quite caught on. They're a little behind, but I think that's ultimately where the field will move. Yeah. Oh, question. Okay. And then I'm going to talk a little bit more about the machine stuff. This is more of an intro. The next thing I wanted to bring up is the types of diseases that we are transplanting. Okay. There's always been controversy, and I guarantee some of you in this room are affected by this, about alcohol as an indication for liver transplant over other indications. Okay. And what we would now say in the last 5 years is we don't judge alcoholics, people who drink, and develop liver failure as a isolated self-harm that would lead to a poor use of an organ. Alcoholism is a disease not different from any other disease that we treat. What we do though, and you have to have good faith that we are always using our donors in the appropriate way and matching organs to folks who are going to take care of the organ, is that we have very deep psychiatric and social work teams who are delving into our patient's medical history and delving into their what we call psychosocial history, and ensuring that the patients who are given organs due to a diagnosis of alcoholic liver disease are going to take care of it. All right, so there's a really deep dive that's done. So we're trying to remove the stigma from alcohol as a reason why someone shouldn't get a liver transplant, because that's really the wrong way to look at it. We now view it as a disease that is manageable and treatable, and we plug our patients into the appropriate therapies, and we will utilize transplant for alcoholic related liver disease. And you can see alcohol related liver disease is this purple line, basically since 2017 has been rising off the charts. Now, it's not because we're only transplanting more alcoholics, that's part of it, but it's also because other diseases that we transplant have been going down, right? So hepatitis C up until 2016 was really the most common liver disease in the state of Georgia that we were transplanting for, and that has essentially mostly gone away. All right, why? Because we have curative therapies for it now. So now we're capturing people and treating their hep C and curing them before they develop liver failure, and so they don't need transplant. So we are transplanting a lot more fatty liver disease, and we are transplanting more alcohol-related liver disease than we had ever done in the past. And all of the other rare liver diseases, some of you might have, things like autoimmune liver disorder, some of the pediatric disorders that folks will graduate into adulthood. I don't do pediatrics, so if some in the audience are pediatrics, feel free to ask questions, but I might not always know the answer. And then liver cancer is a common scenario, right? That used to be about 20% of our transplants, mostly because of hepatitis C. It's really decreased to about 10%. So liver cancer is also going away as an indication for transplant. We're seeing more liver cancer. We're not always transplanting as much liver cancer as we did in the past for various reasons. Most of those reasons are good. So this is what the data looks like currently, and we expect the lines to continue to look a lot like this. All right, so I put this up here because this is my least favorite question, and I'm sure everyone in the room has asked the doctor this question in this exact language. You have liver failure, you've been told you have liver failure, you've been told to see a transplant specialist or a liver specialist, and the question says, how long do I have really, and what % of my liver works? And the reason why we don't like this question is because we don't have an answer. We don't answer it in this way. We don't say 30% of your liver works. We don't view liver disease as a function percent like the kidney doctors do or the heart doctors do, right? When you have heart failure, it's a heart ejection fraction of a percent. If you have kidney functions, your kidney functions at a percent. The liver just doesn't work that way. We don't judge it that way because a lot of our complications are not related to the lack of the liver's ability to do its job, meaning digestion and make proteins and make blood clotting factors and all the other magic it does, because it does a lot of things. But a lot of it is related to the plumbing problem that you have with liver cirrhosis, and that is you get scar tissue in the liver, which leads to changes in the blood flow, and those blood flow leads to what we call portal hypertension, and it's portal hypertension that gives people the problems, which circles back to the TIPS shunt of why TIPS shunt works, because the TIPS will fix the plumbing problem in patients whose main issue is plumbing, not liver failure. Follow me? So we think about liver failure and portal hypertension together, but also separate. And that's how the doctors will often recommend one therapy or both therapies for you, which is TIPS shunt or TIPS plus transplant or transplant alone. What we don't do is we don't say your liver works as a percentage, but we use all sorts of risk factors to figure out how well your liver function is. And this is where the MELD score comes into play, right? Everybody's now heard about the MELD score. And the MELD score has evolved. In the good old days of transplant, we used to use something called the Child-Pugh scoring. That's old. It was problems with subjectivity. So doctors were gaming the system and it was unfairly disadvantaging certain patients. MELD score is a huge improvement on that. That happened about 20 years ago now. And then we've been slowly evolving the MELD score because the MELD score in every score always remains somewhat imperfect. There's always somebody who's left behind. And now the new iteration that started last year, or actually this current summer, was MELD 3.0. Let's skip over this slide. And then, okay, so the MELD 3.0 is the newest improvement. And basically, what we've learned when we changed MELD to MELD sodium, which is what we're using for the last 6 years or so, is that the outcomes for patients were better when using the new score. And that now has been predicted to be true and now finally starting to be shown to be true as it relates to MELD 3.0. Now, MELD 3.0 is not really something you can calculate on your own calculators. If you guys Google MELD score and you go onto your lab portal and you try to pull out what your labs are, you're really going to struggle with this. We have automatic calculators that do it for us. The original MELD score is not hard to do. You just plug in a couple of numbers, but then now with MELD 3.0, there's a lot more factors taken in. So what's changed? What's changed is historically women have been disadvantaged because of the body chemistries were different and it wasn't accounting for sex. So now sex is accounted for. And then malnutrition and inability of making certain proteins is accounted for in MELD 3.0. So what we think will happen is the gap will be closed between our patients who had lower MELD scores but were sicker and dying at higher rates because of chronic malnutrition, usually related to what's called portal hypertension, and women were disadvantaged, usually by a point or two on the MELD score. That now is brought up and that gap is now closed. So theoretically, it removes the gender gaps and some of the unmeasured malnutrition gaps we were seeing in the MELD score calculation. Will there be further improvements? I'm sure there will be, but for those of you who are nearing wait list or on the wait list, this is what we're going to see for at least the next 5 years. And this is calculated automatically. You can always ask your transplant coordinators what that score is. It's just continued improvements. Now, livers are allocated based on MELD score, but some of you probably did not have the highest MELD score and got transplanted. And that's because transplant centers will often have various mechanisms to match donor organs down the list to patients based on lower MELD scores, but it's always at some degree based on the MELD score. So you might get called in to get a transplant at a MELD score of 28, but there were 2 people ahead of you in the region who were higher, but for various reasons, whether it was body size or donor characteristics, were skipped over. So it's not always the next goes first, but it's always the next is considered first. Okay, so those 2 MELD score patients higher, they were offered the transplant, but for various reasons, they were skipped. And usually it's because of donor characteristics. We do our best to try and match the right donor to the right recipient to generate the best outcome while taking that risk that waiting for the right liver with liver failure, there's a lower risk of dying, right? So we're always balancing risk of dying while waiting for a liver versus risk of dying after getting a liver. And this is a struggle. We don't have a crystal ball. This is not explicitly told to our patients. This is told to you in various ways. It's just not said in that way. But that's what's happening behind the scenes. A common way I think it would be told to you is you're on the list, you get a phone call, and they say, we got a liver match for you, your MELD score is 27, but the donor, it's always but the donor, right? It's never, we have a perfect liver. It's always, we have a good liver, but the donor. And it's usually a story of, was found down with a needle in arm and has brain death from overdose of drugs. And then what we can't tell you is that needle didn't have hepatitis or didn't have HIV, right? So the risk was that we could give you those diseases with transplant and we deal with them, right? If we thought that was a problem, we wouldn't offer you the liver. It could be that the liver came from a morbidly obese individual who has a lot of fat in the liver, and that can lead to slower rates of uptake and function. But we know how to manage that, and those type of livers are not appropriate for every recipient. So those are the scenarios that you might go through. And there's a thousand of those types of scenarios that will be told to you. But if it's not told to you on the phone by the transplant coordinator, it will always be disclosed to you at time of consent by the transplant surgeon before you go to the operating room. All right, I'm going to pause here. I did a lot of talking and I don't want to do that. What questions do you guys have? Anything tickle your brains yet? And we got the online questions too.
Yeah.
So please free-form any questions.
So for Mel 3.0, are there any parameters that are put in there to help the folks with autoimmune liver disease?
No.
Okay.
So there's nothing in a organ allocation standpoint via MEL 3.0 that is helpful or harmful for any type of cause of liver failure. However, that being said, there are ways for doctors to ask for exceptions to the MELD score and to get patients higher up on the list based upon certain characteristics that we know lead to worse outcomes while waiting for transplant. Okay, so common ones will be liver cancer. Patients with liver cancer have higher rates of dying while waiting for transplant based upon their natural MELD score. So they are given a special priority for transplant. And there's various other conditions that can occur with liver failure that are given also special priority. Another one that we never like to see, but is always justifiable, is when things don't go well after the transplant. Patients who've had a transplant and are suffering after the transplant because of the transplant are given special priority to get a new transplant. Any questions online?
Any questions?
Well, I've got another one. I'm so sorry, you guys. When you were talking about matching the donor versus characteristics, and understanding a lot of it is a judgment call too. But what you mentioned, size was one of them. What can some of the other ones be? I mean, is there any truth to a female should get a female liver and a male should get a male liver or anything like that?
No. So all we care about immunologically is blood type.
Okay.
There's nothing else that predicts higher rates of rejection post-transplant. I mean, it's a little more nuanced than that, but to answer that question is sex doesn't matter, race mismatch doesn't matter,
Okay.
right? Most donor medical conditions don't matter. What often matters is recipient medical comorbidities. So it's prior surgeries influence these decisions, right? How much scar tissue is there and how much time will the surgeons need to remove the liver? Is there a blood clot in any of the veins feeding into your liver or out of your liver? That factors into that decision making because it increases complexity of transplant surgery, and time is of the essence. Other ones would be history of certain kinds of heart disease. And when I say there's a matching of recipient and donor, there are certain conditions that we will see in the donors that would make the ability of the liver to work or the stress on certain organs, including the heart and kidneys, higher after transplant surgery. So we try to avoid those types of organs, right? The highest risk organs will do extremely well in the healthiest patients. And so the higher, quote unquote, higher risk organs, being organs that have some issue with them, but not bad enough to make them unusual or unusable, will be purposefully placed in those who we think are going to be able to rebound from surgery quickly, essentially. All right, let's do you in the back and we'll do the gentleman next.
When it comes to fatty liver disease, is there anything that can be done prior? I mean, once it's known, is there anything that can be done while you have an idea?
Yeah, so question is, in case folks online don't hear well, so fatty liver disease, and let's be specific about what we're talking about because the nomenclature is changing. So what we call these diseases is changing. We classically would call fatty liver disease non-alcoholic fatty liver disease. That language is being removed from us. We still use it, but we're being told not to use that language. Not by anyone other than the liver doctor societies are trying to move it towards what's called metabolic associated liver disease, because it really is a metabolic disorder, not related to alcohol, right? So there's alcoholic liver disease and there's non-alcoholic. So the non-alcoholic, we're changing the name to metabolic associated liver disease because it's associated with metabolic disorders. Those would be things like diabetes, obesity, in some women, polycystic ovarian syndrome, high blood pressure, high cholesterol. It often runs in families. The genetics of it, we don't fully understand. The treatments for that are, if you haven't yet developed liver cirrhosis, is yes. The thing we know that works is diet, exercise with weight loss. Obviously harder for some people, and it doesn't work for everybody, and it's complicated. And there are drug therapies that potentially can help. Nothing is approved for use in the United States for metabolic associated steatohepatitis or fatty liver disease. We do recommend things like Ozempic when it's appropriate to use in our patients. Appropriate use would be those with diabetes and or obesity because it does induce weight loss and it helps the diabetes and it also removes fat from the liver. But it's not approved for use in fatty liver disease. So if you only have fatty liver, no doctor can get it for you. And there are drugs potentially that might be available in 2024 for fatty liver. So things are changing in the world of fatty liver. The question then is, if you already have liver cirrhosis because you've had fatty liver disease, whether you knew about it or not, a lot of our patients come to us not having known that they had fatty liver. The answer is no. There's no treatments. If your liver function is good, same recommendations: diet, exercise, weight loss, Ozempic, etc. If your liver disease is more advanced, then we're talking transplant. Yes, sir.
Yeah, I have a statement and a question. I'm just wondering, it appears to me, I don't want to personalize it, that Piedmont discriminates against people who come from other transplant centers. Seems to be an unwritten rule or policy that if you're from another transplant center, Piedmont does not take you. And I'm trying to figure out how does that fit in with the mission statement that Piedmont has.
You're coming at me with a controversial question. All right, so the question on the table, if you guys can't hear, and I will be honest with you, and I can speak with authority on this as the medical director of the program, okay? So the question is, this gentleman feels that Piedmont Transplant Center, and I don't know who you are, so
My name is George Thompson. I'm a 15-year transplant recipient coming from New York to the great state of Georgia.
Okay, I got you. So you relocated, okay. So the question is, feels that, and I won't say Piedmont, although I said it, transplant centers in general are not quick to adopt patients who have been transplanted elsewhere. That's the question on the table. And I will answer it this way, which is all patients are free to move about the country, right? Who've had a transplant somewhere else. And there's an obligation to take care of patients. What we have found in the transplant community, and this is a very controversial topic you're asking because we struggle with this. Every transplant struggles with this. And particularly in the world of virtual medicine has made this really easy for us, is that we transplant patients and we feel tied to them lifelong. And that is, when I say we, I mean the transplant community. So what we expect in the community, and this is the general practice, which is wherever you've been transplanted, you shall continue to receive your long-term transplant care at that center. Before you speak, I can see your eyes. That being said, our policy in general is we will not adopt patients who have been transplanted elsewhere because they have a transplant center who is capable of taking care of them. But the carve out for that is we always will accept the patient when that center calls us. So I think what you might be experiencing is you're calling for an appointment and you're being told no because we haven't been contacted by anybody from your transplant center asking to be taking over your care. So it's really a doctor-to-doctor handoff is the process, and that's generally the national behavior.
My transplant record, hepatology at your sister medical has been calling this institution. No one is calling back.
Yeah, I apologize.
Several
I'll take your information. I apologize, and I apologize for going through that because those phone calls usually come to me, and I've never heard of your situation. I apologize. Yeah.
some
Yeah.
questions. I was transplanted in Emory. I'm here now.
Mhm.
I slipped through the cracks also. I was kicked out because of insurance, not living back in the country. And I don't get information from anybody for anything unless I see it myself. No one contacts me for anything. So I know exactly what you're going through.
Well, I didn't mean to turn this into a Piedmont event. Jeez. You guys are a tough crowd. I apologize for your experiences, but you all have transplant coordinators, and they really need to be your point of first contact. And
Just, you were just saying that you had not
Yeah.
heard something like that.
and I'll tell you, and again, not trying to be defensive in any way, but the experience for our patients should actually, in a perfect scenario, be just that in a way, meaning that once you get to 2 or 3 years after transplant, you really should be in cruise control and no different than a transplant. There, however, are patients who have ongoing care needs, and obviously we're doing a lot more work on that.
Okay, that's one of my questions then. I met the transplant doctor when I started here at Piedmont. I was listed here, and because of insurance, I had to switch to Emory. And then because of insurance, I had to switch back here. And my coordinator at Emory does no long-term forever care because she said, let me know when they accept you so I can delete all your stuff. But I met a transplant doctor here. He's a friend of mine's GI, and he, I was wondering if I could go to see him. He's in, I live in Gainesville.
Yeah.
He has an office in Gainesville.
Yeah,
Instead of
yeah.
coming here.
Yeah,
I
yeah.
see Dr. Senior. I love her, but it's far.
Yeah. So that's it. So we are going back to that, like, post-transplant management. This is the easy stuff,
But
right?
he said, when I talked to him, he used that what you said. Well, you're kind of cruise control now.
So I will tell you what we say, and Mr. Hamilton, is that your name, Hamilton? Thompson. Mr. Thompson's experience, I think, could be unneeded if. So here's what we've had these phone calls with other medical directors at other transplant centers, right? We have meetings like this in rooms, and the question is, every year we're transplanting 10,000 new people, right? But there's not really new doctors being created in the world of transplant. It's a very small field. And so every year, every transplant center starts to feel the weight of the care of patients long term, right? And we want to do it well. And we want to do what's right for you all. And the question is, how do we do it well? And how do we keep bringing patients in, keep transplanting patients, and keep taking care of patients long term who need our care? And can we lean on the community, in particular in the state of Georgia, which has 2 transplant centers only in Atlanta, which can be a 5-hour drive from some parts of the state, right? And can we lean on our local community partners to do the long-term care that you need? And the answer is yes. And what we have been doing by recommendation is somewhere around the 5th year in general. And the reason why the 5th year is there, because if you've made it 5 years, whatever disease is going to recur almost always would have already recurred. We would have seen it. And also, I mean, that's the main issue, right? Like, whatever would have recurred, whatever care needs you would have had, would have declared themselves by then. Now, can something happen later down the road? Sure, we'll bring you back, we'll fix you. So what we generally do at that point is we talk to our patients and we say, this is where you're at. You've made it 5 years. Congrats. You've had 0 transplant-related complications. You're coming in here and all we're talking about is vaccinations and mammograms and colonoscopies. And this is the kind of stuff that primary care doctors do. And you could go back to your primary care doctor or go back to a local GI provider who feels comfortable seeing you long term. We are totally okay with that. In fact, we are highly encouraging of that. What we have found, though, is that there are very few clinical partners in the communities who are willing to receive that they don't feel comfortable prescribing tacrolimus, that it makes them nervous. And we're happy to give that education when we get those phone calls and we say, no, you can do it. It's not that difficult. And so what we've done to help bridge that gap a little bit is to allow our transplant coordinators to stay involved with your care, but then say you don't really need to see the doctor every year if you're seeing someone.
My next April, I will be 5 years. And I've been seeing them this year.
Yeah.
I know that I have to come here.
Yeah. And I don't know who your doctor in Gainesville is, but if it's Dr. Ilias, he's excellent. Yeah, so he's a transplant hepatologist who's up in Gainesville, and he works here sometimes, so he would be great.
That's
Yeah.
awesome. I do have some other questions, so.
You're next. No, let's do this. We'll do her.
Does Piedmont have satellite transplant centers?
Yes. So not transplant centers. So
Right.
transplant centers here. We visit all throughout the state. I say we try to bring transplant to the 5 corners of Georgia. We used to go as far south as Albany. We moved that clinic over to the Columbus campus. So we're in Columbus, we're in Macon, Augusta, Athens, Dalton. I feel like I'm missing one, but that's where we're located. So we have clinics all throughout those areas. Those clinics are in general, though, we use them to bring transplant access to patients in those communities to decrease the burden of the travel. We don't have the capacity to do all the post-transplant care in those locations, unfortunately.
So no aftercare?
No aftercare. We do aftercare. We partner with video visits for aftercare if travel is a burden for our patients.
Okay.
Yes. I'm coming back to you, don't worry.
Okay. Let's see, I have a scenario where I have cirrhosis of the liver, and I also have fluid buildup, which causes a hernia. Well, to treat the hernia, they give me medication to get fluids off, which is shutting my kidneys down, which is, I was on a kidney liver transplant list. Well, because of the kidney issues, they said, let's quit taking the diuretics. And my MELS score was 28, and after they took me off, it went back to 18, I think. But now I'm having issues, severe issues with the hernia. And they're more concerned to treat the hernia because it's unoperable. But do they have a different way of looking at the transplant? I know with the MELS score was high, they was hoping then. But now, because of the other issues, I can't treat the kidneys, but well, they treat the fluids to keep the hernia. But now it's affecting the kidneys again.
Yes, you're in a tough position. So you are a classic example of why we need more donors, right? Because you have a clear need for transplant today, but are not getting access to transplant. You're on the list, right?
Yes.
You're not getting access to transplant because of your lower MELD. The MELD score will always fluctuate, and the doctors are clearly balancing the risk. You're not yet on dialysis, it sounds like.
No.
Yeah. So nobody wants to see you end up on dialysis because your quality of life will decrease, your risk of dying on dialysis will increase. So they're doing everything to maintain your kidneys, but at the risk of you having fluid and feeling miserable because you're swollen. And you're in a tough spot, and you need transplant today. I mean, that's the reality, but you don't have access to transplant. You're on the list for both a liver and a kidney?
Well, the kidney is 50-50. It depends.
Yeah.
I was, and they took me off, and I said, well, you know, it's borderline.
Yeah. And
They're hoping to get the transplant. And they get the transplant, take good fluids, which makes the liver should be, hopefully be fine. I mean, the kidney.
Yeah. I mean, you would be someone classically that we'd be talking to about a living donor transplant. The negative there is, can your kidneys handle it? And is there a donor that's going to be big enough for you? And do you even have a donor that's available? That's the struggles, right? But ideally, you would get a deceased donor transplant and you'd be able to get it as fast as possible. And this is where maybe some of the machine technologies might end up helping you in the long run. Yeah.
Has the live liver transplant program restarted?
We have not. We have no plan to restart here. We stopped doing it about 2 or 3 years ago. We have no plan to restart because we have found other strategies to help our patients with lower MELD scores that don't involve the risk to the donors. Emory is doing them in the state, or about to start doing them in the state. All right, back to you.
That chart you were showing that had all the lines of different kinds of liver disease.
Yeah.
The alcohol-related liver disease is going way up.
Way up.
Do you think that possibly that's not just alcohol contributed to that it is our lazy lifestyle and fast food and all that?
No, so that's accounted for in what's called NASH. So you can see that one is also rising. And the answer to that question, I wouldn't say our lazy lifestyle and food.
You know,
I would say that,
kids don't play outside.
yes, I would say that the United States and Western societies have not figured out what the problem is, but there's clearly problems, right?
But with the new nomenclature coming out, there is a part for people that have fatty liver and alcohol related.
Correct. There's a mixture.
Yeah.
So yeah, we see patients who drink too much, but also have all the risk factors for metabolic fatty liver disease. So there's this crossover. Some patients get both. You're after her. No, go ahead.
Why do you think so many people post-transplant are getting stents?
Biliary stents.
Yes.
Biliary stents. Okay, so I don't have a picture of the liver transplant surgery here, but there are four vessels that are reconnected, right? There are the hepatic veins. That's the veins coming out of the liver. And anytime the surgeon is attaching stuff, there's a risk of narrowing or kinking or scarring that can lead to problems. So that's problem number one. Problem number two could be the hepatic artery. That's the most worrisome one because that leads to the liver failing. Three is the portal vein, which is the blood coming from the intestines into the liver. And then the fourth is the biliary system or the bile ducts, right? The digestive juices coming out of the liver into the intestines. That connection is extremely sensitive to lack of oxygen. And during transplant surgery, those nerves and blood vessels are cut off, and the blood supply to the furthest reaches of where those cuts and reattachments are made are thought to develop scarring due to lack of oxygen early after transplant. And you tend to see the effect starting around the third month or more after transplant. About a third of all patients in the United States will need some biliary procedures to fix that.
Do you think the risk of that is over after a short period of time post-transplant? Of maybe one?
The risk
I did
goes
not.
down, but it doesn't go to zero.
But I did not need one, and I haven't had bone marrow.
Yeah.
And
Yeah.
I
So,
know a lot of people.
but again, your experience is the majority, right? 2/3 of patients won't have the need for a stent or an ERCP procedure. Some of our patients get it really bad where they have all sorts of drains and external stents, and those can last a year or so, particularly living donor surgeries. All right, you.
Tackling the question. Yesterday I was doing some work around. I couldn't remember where I took my medicine, and I took it again. And trying to find if you double take it,
Yeah.
you could wind up in any kind of problem.
In the short term, nothing bad will happen to you.
Oh,
Your level that day just might be higher than expected,
oh.
but it's unlikely to cause problems. It's the same would be true is if you forgot to take your medicines that morning, right? You miss one dose, nothing terrible is going to happen to you. So let's say you normally take your medicines at 9 a.m. and you call us at noon and you say, oh my God, I forgot to take my medicine. What do I do? The answer would be just go ahead and take them, right?
Mhm.
But if it's 9 a.m. you missed and you remembered at 6 p.m. and you called us, we would tell you don't take it because that's the risk of double dosing, right? And just wait until 9 p.m. All will be well, don't worry. Now, what we don't want is that you're missing lots of doses, lots of the time, because that's when you put yourself at risk for rejection. Oh, we're cruising. Good. This is going well. Let me get you in the back.
How long do you normally stay with it?
Is that Steelers? What is that back there? Steelers? All right. Well, send the question when I was distracted by your jacket.
Rejection. How long do you normally stay in rejection? Depends on the body.
Yeah, it's a very variable course. So the rates of rejection after liver transplant fade after the first year. We tend to see it somewhere between around 10% of our patients. It's a common scenario. It is not a problematic scenario as it relates to the health of you long term. It's a meddlesome problem that leads to hospitalizations and biopsies and changes in medicines.
But since I've been having a liver transplant 8 years now, and I'm the third one I've been having problems with liver ever since. I went in rejection in April, headed to rejection, and I didn't come out of rejection because when they noticed I was going in rejection, they had me take my blood work every 2 weeks, every month, and then each time I go, it was getting higher and higher, and it just started leveling off until August. In September, that's when I came out of rejection. Went back to normal.
Yeah, so that's a common experience, right? So particularly, if I understood you correctly, it happened 8 years after your transplant.
I've been today, but yesterday is 8 years since I have transplant.
Yes, but the rejection started 7 years after your transplant, right?
This year.
This year, yeah. So a long time after your transplant. So most rejection will occur early after transplant, but we can see late rejection. And that's why, again, going back to, can I go back to my primary care doctor? This is what we recommend in general is labs every 3 months for life. Sometimes some patients can make it 6 months between labs, but never less than that, because you want to be able to detect on the labs the early changes in the enzymes, because in your case is probably a good example. The sooner you catch it, the earlier it is to treat. The later you catch it, and you don't know how long it was going on before you caught it, the harder and more stubborn it can be to treat, but treatable as in your experience.
Well, I had one of the injections before, 3 years ago, and they had me in the hospital to do my biopsy, to see what was going on. And by the time, somehow with my insurance, so they had to delay it. And I went back 2 weeks later, got blood work, and the rejection was like coming back down. And almost started heading back down.
Yeah. So, very common scenario, but you're doing well, aren't you?
I'm still here.
Yeah. So there you go. Power. So the reality is that we always talk about rejection. Rejection seems scary to our patients, and rejection is something we're always looking for, and sometimes can be hard to treat. It almost never leads to people dying after a transplant. Yes.
I don't know if this relates, but if you have a fatty liver, I had a friend that had a fatty liver. A couple years later, she came the diagnosis of Lou Gehrig's. Does that have anything to do with a fatty liver?
No connection. To
But she had
So,
fatty liver first.
fatty liver disease is the most common liver disease that we see.
Okay.
We think it is present in up to around 10% of Americans. So when you have a common disease, other uncommon things can happen along with it, but they're not associated.
Okay.
Are you seeing any move to eliminating anti-rejection drugs in long-term patients?
Yeah, that's always a field that's been studied. People spend their careers on this stuff. We haven't gone to immunosuppression withdrawal. It's called immunosuppression withdrawal. If you look historically and classically at the data, about half the patients can successfully do it. What we don't know is what are the risks, what are the factors that make the patients going to be more likely to be successful versus those who aren't. And that's what's missing to make it a safe recommendation across the board. What we do as a practice, and almost all transplant centers behave this way, is that we will slowly reduce immunosuppression over time, in particular at 6 months, at 1 year, and then often further down the road. And we monitor patients for rejection as we do that. And we'll sometimes see it, we sometimes don't. What we hate, though, is when we do get rejection, because then you play catch up. You actually start all over again. You give them much higher doses of immunosuppression, and then it's harder to get you back down. So we like to avoid that scenario when we can, but we also are trying to balance the risk of cancers and infections that are related to immunosuppressive therapies and kidney damage.
Heart issues.
Yeah, heart issues.
High blood pressure.
Yep, all of it. So what's the number one killer in a patient who's had a liver transplant? Heart disease, right? So what's the most common skin cancer we see after liver transplant? Any transplant? Skin cancers, yeah. So not deadly skin cancers, but so everyone has to see their dermatologist and get recommended. Were there online questions?
Yeah, no.
Just pop-ups of hurry up, you got 5 minutes
I
left?
think they come up with the date, and I apologize, I really think that's
Okay.
wrong, but no.
Okay.
Nobody here.
Sounds like we got 5 minutes left, 4 minutes left.
One quick thing for the perfusion machine.
Oh, we didn't get to that. Let's do that real quick.
Yeah, I was just gonna say, because I think, what was it, like 4 to 6 hours was the time frame for livers, and then how much longer does it give you using the perfusion?
Yeah. So I think so this is what machine language is. This is what we define this stuff as. This is the pumping technology. There's 2 products on the market that are being what we call normothermic machine perfusion, okay, which is Transmedics, which is a machine that goes to the donor, and then Organox, which is a machine here that when the liver comes here, we then connect it and pump it. I think these are going to be game changers. This is to get DCD donors, right? The biggest loss of potential organs in this country are those who die by cardiac death, but have good functioning organs. The reason why we don't love cardiac death organs historically is because of the biliary complications that are much higher rates with them, because there's a shock of lack of oxygen to the liver for a minimum of 5 minutes. That's how the process works. So what you can do is you can reconnect the donor organs while they're in the donor to a heart-lung machine, which is ECMO, and then recirculate and pump and monitor the organ's health after the patient has been declared dead. Okay, so that's one aspect. And then this is what we're talking about when we talk about machines that we're utilizing. And what this will allow us to do is to now use organs that have died by cardiac death, who maybe are outside of the usual cardiac death criteria, or even outside the distance from the transplant hospital to allow for longer transport times. And then this other technology can allow us to utilize organs that we're unsure about because it gives us time. The other benefit I think that's not ever talked, so the biggest benefit to you all is increased number of organs that are viable and healthy and able to save more lives, right? More people can get transplanted because now we suddenly have created more donors. The other thing is make sure you're advocating for increased donation across this country, right? And trying to advocate to your politicians about making donation an opt-out rather than opt-in. Because if it were an opt-out, something that the countries that have opt-out, it's like 95% donation rates.
I think the latest is we're only one of 5 countries in the world
Yeah.
that have the opt-in system.
When it's opt-in, the presumption is you didn't want to donate unless your loved one who speaks for you at time of death changes that, which, you know, the OPOs know this data, but it ain't great. All right, so we can utilize these technologies. So it's basically a bag of blood connected to the liver. These machines will travel with the donors back to the hospital where you would receive your liver transplant. The transplant can be monitored. The most interesting part is these livers are working on the machine and they're making bile. So really making bile is the digestive juice that the liver creates. That's how we know they're working. They're not making bile and the liver doesn't look pink and healthy, then it's not a good liver. And you can measure the liver enzymes and you can measure other aspects to ensure that the liver's working. But really all you need to make sure is that it's making bile at the appropriate bile making rate and all is well. But this is the benefits, right? So it reduces the complications we should see with transplant. That's a lot of that biliary stuff goes away. So historically, when we utilize an organ who dies by cardiac death and we don't pump it, and we give them to our patients, a third of those will develop severe injury related to biliary complications. The reason why we do it, though, is that the death rates aren't higher. So survival rates after transplant the same, it's just the complication rates are higher. So we use them, but there's problems. And the quality of life can suffer in our patients who receive those organs. This new technology, the data says it goes from 30% all the way down to 1%. So now 1% of patients will have this problem. So basically we've eliminated the problem. So that's the huge benefit, increasing the number of donor organs that can be utilized, decreasing the number of complications. And then I think the thing that isn't ever spoken about is this last one, which is liver transplant performed at convenient times, which is the burnout to our surgeons is extremely high, right? It's a 24-hour/7 job. They're entering into often 6 to 9 hour surgeries that often start after midnight. And they get exhausted. And so the average transplant surgeon's career ends in their young 50s. And I think what this technology will allow us to now do is to time transplant surgery to start during daylight hours, which doesn't affect just the surgeons, it affects the anesthesiologists, it affects the scrub nurses, right? Scrub nurses have high burnout rates too for the same reasons. So the team is going to have a lot more longevity, more experience, outcomes overall should improve, right? I think that's the unspoken stuff of what this technology is going to bring. All right, so that was the speech on the machines. Yeah.
So after transplantation, how does it go about blood, like if you need a blood transfusion?
If you need a blood transfusion, you get a blood transfusion. There's no concern.
Like 6 months to a year?
No, there's no concerns about blood transfusions after transplantation. Are you worried about like the risk of causing it to cause an immunologic problem?
Yeah,
Like rejection?
yeah,
No, because you'll have matched blood donation.
okay.
So there's not too much of a risk. It's just CMV is the infection we worry about for some folks, but that's monitored for also.
Well, that subject now, can we donate blood?
Haha. You should be able to donate blood. But I think the policy still is organ recipients cannot. I don't think that's
Because of
changed.
the anti-rejection medication.
By what?
You can't because of the anti-rejection
Yeah,
medication.
yeah.
Does blood type make any difference? No.
Yes, so that is the biggest thing. Like you cannot have a blood type mismatch. There's a couple of carve outs and exceptions to that rule, but in general, your blood type gets matched or you receive an organ from an O donor, the universal donor's O.
I have O negative blood. Yes.
So you can only get O donors, which limits also your ability for potential donors.
When transplant recipient be a donor?
Yes, the answer is yes. In general, if it's a liver recipient, they won't reuse the liver, but like the kidneys, and the cornea, and the heart, and the lungs should all be good. Again, they do all visual testing, but the answer is yes.
Don't forget skin and.
Yeah, so
and-
all of you who've had transplants, keep your box checked for donation. They may not end up using them, but you're available for donation. Yeah.
Since the cost of death of most transplant is high, so how do they protect their heart?
Say that one more time because you weren't speaking very loud.
I said, since the cost of death with the transplant recipient is heart disease, how do transplant patients improve their heart health?
Yeah, so it's a general health question. The question was transplant recipients in general have much higher rates of heart death compared to the general population. So number one cause of complications and death after liver transplant. And how do you monitor for that? And that's where, again, plugging in. So we are often going through that checkbox when you come in for post-transplant visits, discussing your diabetic control and high blood pressure control, known complications of the transplant medications, right? Weight gain is another one that occurs very commonly after transplant. That's another risk factor for heart disease. The answer is we need to partner with our primary care specialists to ensure that all of the usual care that our patients would be getting are being taken care of. And if cardiologists, et cetera, are necessary, then that's what's necessary. There's no, we don't do routine stress tests in the absence of symptoms, if that's what you're asking. Which would be, but what you could consider doing is a calcium score. So this is done on all of our pre-transplant recipients, is doing a heart CT scan looking for cardiac risk based on the amount of calcium in your heart. And that can be done down the road after transplant too. We don't recommend that because there are no general recommendations for that, but that is something that the primary care doctor definitely could do. Yeah, I think we're good. Last question.
Can you explain to me, because it was after transplant that I heard of it, about the cross matching, like if your organ, if you can't get that blood type, like you were saying, they'll match it with somebody else?
I don't know what you're asking. Are you asking like
Paired exchange?
like a paired exchange? Yeah.
Yeah,
You're
like-
talking about like a living donor situation?
Yeah, if you're, like, let's say I'm blood type A.
Yeah.
And then, I need a kidney, and then they can't match with that one, but they match with us.
Yeah. So what you're talking about, there's kidney has gotten really good at this. Liver still remains far behind.
Okay.
But there are all of these computer algorithms that can match patients up what's called paired exchanges.
Mm-hmm.
They have those for both living donor kidneys and they have them for deceased donor kidneys.
Okay.
And in the kidney world, it creates these chain reactions of these folks who, and it always starts with a donor, right? Someone has a living donor and wants to give to their sister but can't. So that living donor agrees to give it to a random stranger with the promise that the sister will then be matched with someone through that chain.
Okay.
And there's these computer algorithms. I don't know the details of how the kidney team does it. I've seen these lectures and they go through like all of these mappings. There are all sorts of articles in the lay press about really heartwarming stories of how those have worked out well. We really need something like that in the liver world. The problem is it requires often altruistic donors, which we have, but are harder to find on the liver side, just because the surgery is so much bigger. The time out of work is so much greater. The risk to a donor is so much greater. So people are more scared. But yes, that is also the future, which is getting better at doing those things. Any strategy that will increase donation and transplant rates is necessary. And some are harder to correct than others.